Right. So good evening, everyone. Hello. It's nice to see you all again. Thank you for CPDme for inviting me back to talk about cranial nerves. It's great to be talking to you tonight. I didn't expect this to be so popular, but then I'm always surprised at how popular the clinical examination webinars have been. So it's really good that you've given up your evening to come and listen to this. So thank you very much. I hope that you find it useful. Right. So obviously, hello, my name's Chris. So I'm currently working as a GP trainee in the north of England. Last year I worked for a medical school and I was actually a clinical teacher in neurology and renal medicine. So I've got a bit of an interest in kind of teaching clinical examination and neurology to medical students. And of course, this is Maggie the dog, who, if you listen to any of my webinars, will know that Maggie the dog makes an appearance on every webinar. And this is Maggie meeting one of our chickens. And you would think for a retrieving gun dog, she would be quite interested in chickens, but she's actually terrified of them. And they chase them around the chickens chase around the garden. So bless her. So if you want to stalk me, find out a bit more about what I've done, you can follow me on LinkedIn if you wish. And I'm always happy to answer any questions. You can send me a LinkedIn message, etc. So you can scan the QR code if you wish. But let's get into the webinar, really. So like I said, I've done a couple of these clinical examination webinars before, and really we're now going to be talking about neurology for this webinar, and I've got a webinar next month where we're going to be talking about the limb neurological examination. But if you're interested, if you're, I don't know, revising for exams, if you've got OSCEs coming up, or you just want to maybe refresh your knowledge of examination, then we've got a series of webinars which you can watch on the CPDme website. So abdominal exam, cardiovascular, and respiratory. Okay, so they're all available to watch for free. So what are we going to be doing this evening? So we're going to be talking about cranial nerve examination. This is quite a tall order to talk about this in about 45 minutes. It's going to be quite difficult, and hopefully I've reached the right balance in this webinar. So it'd be great to get some feedback from you all. So it's going to be a crash course. We're not going to exhaustively go through each individual step and break it down bit by bit, because we'll be here for hours. We'll be here all evening. So instead, we're going to definitely cover an overview of the cranial nerves, what they are, how we examine them. But I would suggest, in order to get the most out of this, that you perhaps watch some clinical skills videos and examples which are available on YouTube. So there's obviously some great resources from Geeky Medics, McLeod's clinical examination videos. So watching a step-by-step video. And also it's useful to maybe think about this in conjunction with your experience in practice. So maybe you're already performing cranial nerve examinations and you're feeling relatively competent in this skill, or perhaps you're a learner and you're new to performing cranial nerve examination, in which case you might want to undertake some practice under supervision and maybe think about reflecting on your experiences. And I'll signpost you to various useful resources as we go through the webinar, so that I don't end up spending a lot of time talking about one topic in particular. My advice would be, maybe if you've got a pen and a paper handy, or your phone, or if there's at any point something that you're not familiar with that we're talking about, just make a note of it, and then you can look it up after the session, maybe write a reflection on it, upload it to your CPDme account, and there you go, you can complete the learning cycle. Great, so we know what we're doing. It's going to be a crash course, and hopefully I've pitched this at the right level. So I've kind of thought about, we're structuring it in an OSCE way, and I've aimed this at more novice learners. So I apologize if you're performing cranial nerve examinations every day, then maybe some of this will be repetitive, but hopefully it's useful to refresh your knowledge. So maybe let's start off with a really simple question, which is, what are the cranial nerves? Perhaps the most important question of the whole webinar. So I think there's quite a lot of you tonight, so I can't really pick on anyone. And obviously I wouldn't do that anyway, but maybe if anyone wants to be brave enough to have a go at thinking about, if you had to answer this question, maybe you can jot down an answer at home, or if you're feeling very brave, you can pop it in the chat box. But if kind of someone asks you, what are the cranial nerves? What would you come up with? I'll give you 30 seconds or so to think about that, how you would answer that question. And you can all look at this meme of Grumpy Cat, kind of thinking about how learning the cranial nerves is awful. Okay, good. So some very brave person, Phil, has put in 12 paired nerves that originate from the brain directly. Good. I think that's a good definition to start us off with. Okay, good. Something you learn for exams and forget. Ah, yes, I agree with that, Laura. Yeah. And someone is starting off a rather rude mnemonic. Excellent. Good. So I'm glad there's a bit of pre-existing knowledge here. So the cranial nerves, let's think about them briefly before we get into examining them. So the cranial nerves are 12 pairs of nerves that arise directly from the brain. So the cerebral cortex and the brainstem. So the first two nerves, so cranial nerve 1 and 2, arise from the cerebrum, and the remaining 10 nerves arrive from the brainstem. So that's the midbrain, the pons, and the medulla. Okay, so that's the first thing. So that's in contrast to spinal nerves. So spinal nerves that, control your arms, your legs, arise from a spinal cord segment, okay? So cranial nerves are different. They're arising directly from the cerebrum and from the brainstem. And they usually, well, they exit the skull through cranial nerve foramina. And if there are any medical students listening to this, I'm sure there might be a few, you will remember in your first year or second year of medical school having to learn all of the cranial nerve foramina and which nerves pass through them. We're not going to go into that level of detail tonight because it's boring and not very clinically relevant at the moment. So as someone rightly said in the chat box, the cranial nerves have sensory and motor functions, and they're responsible for sensory and motor functions in the head and neck. And really, that's the best way to think about the cranial nerves. Just think of them as head and neck nerves, because that's what they are. So they're responsible for kind of general motor functions, such as moving our facial muscles. They're responsible for kind of normal sensation, so the skin to our face. But then they're also responsible for some of our special senses, so taste, vision, hearing, smell, etc. Now, many mnemonics exist for learning all of the cranial nerves. Some of them are quite rude. So I haven't repeated any mnemonics here, but if you just Google cranial nerve mnemonic, you'll get lots and lots of them. But I'm not a big fan of using mnemonics for cranial nerves, and I'll talk about that shortly. So when we're thinking about pathology, problems can occur at different anatomical locations that can cause different cranial nerve pathology. So there could be a problem, for example, in the brainstem or the cerebral cortex itself. There could be a problem in the cranial nerve nuclei, which is kind of like the control center of the nerve, or there could be a problem with the nerve fibers themselves. And in this webinar, we're not going to go into lots of detail about neuroanatomy, but it's just worth thinking that if you're interested and you go and look up or open an anatomy textbook, it can get quite overwhelming, but it does help you think about where the anatomical problems are if you have a little bit of knowledge about the course of the cranial nerves. But we're not going to go into a lot of detail about that tonight. Good, so we know what the cranial nerves are, so let's have a look at them. So here's our 12 pairs of cranial nerves. So they're conventionally numbered using Roman numerals, which when I was a first year medical student, I didn't know Roman numerals, so I had to learn that. So that was pretty hard. Conventionally we use Roman numerals, and then, or you can use the name. So the name of the cranial nerve is useful to remember because it gives you a clue as to the underlying function. Now, the numbering can seem completely random. So why is olfactory nerve number 1? Why is facial nerve number 7? Why is the vagus nerve number 10? But if you look at the underside of a brain, so this diagram here, we're looking from underneath, we're looking at the bottom of the brain from underneath, you can see that the numbering of the nerves makes sense. So the olfactory nerve, if we're thinking about superior to inferior, olfactory nerve is number 1. Optic nerve is number 2. So when the cranial nerves were numbered, this is how they were done. So it does make sense. If you look at the bottom of the brain, they're numbered by how they emerge from the brain and the brainstem. So it makes a lot more sense this way. So you can start to see how the numbering system actually has some logic to it, rather than just random numbers that we've plucked out of thin air. Good. So we've talked a bit about what the cranial nerves are. We know that they arise directly from the brain. So cranial nerves 1 to 12, obviously. So cranial nerve 1 and 2 arise from the cerebrum, and the rest of the nerves arise from the brainstem. So the midbrain, the pons, and the medulla. And we've looked at the numbering system. So what's the secret to learning the cranial nerves? So like I say, I'm not a big fan of using a mnemonic. I think the secret to learning the cranial nerves is to try and integrate your knowledge. So if you just try and remember a list of all of the nerves, it's going to be really difficult to remember. So I remember I used to be able to recall all the nerves up to facial nerve, which is number 7. And then after them, my mind would go blank. I couldn't really remember anything after cranial nerve 7. So I find trying to memorize them just as a list is really quite difficult. What's a lot easier is to remember little bits of interrelated information. So remember the name, a bit about the anatomy, how you test it, and a bit about clinical relevance, and try and integrate all of this knowledge together. And I find by doing that, it's a lot easier to remember the cranial nerves, rather than just remembering a list of 1 to 12. So let's talk about cranial nerve examination, which is obviously the topic of this webinar. So we're going to go straight into it. We're going to work through the nerves from 1 to 12. And we're going to look at what I've put on this slide. We'll look at obviously a bit of anatomy, the nerve's function, how to test it, and the clinical relevance. Right. So before we start, and some of you that have listened to my previous webinars will have remembered some of this information from before. But if you're performing an examination, both in an OSCE, or maybe you're doing it as part of a workplace-based assessment like a mini-KEX, or maybe you're doing this for real, then it's really important that the preparation steps before the examination are well performed. So I quite like the mnemonic wiper, although it's perhaps less relevant to cranial nerves as it is to other systems examinations. But it just reminds you that you need to wash your hands. We probably need to expand that at the moment, don't we, to don all of our PPE that's required. It's important to introduce yourself, obtain permission and consent from the patient. We don't really need to think about exposure, but repositioning them, it's useful to have the patient sat in a chair or sat upright for this examination. So the other thing with a cranial nerve examination, like all neurological examinations, is that if you've got access to equipment, then it's useful to gather your equipment. And a long time ago in medical student OSCEs, they would try and trick students out by maybe not providing all of the equipment, or by providing different types of tuning fork, and students would have to choose the right one. But we're a lot nicer now. And you may be performing these examinations in a setting where you don't have access to this equipment. So if you're in the back of an ambulance or in an A&E department, it's really quite difficult to find a tuning fork. Even a tendon hammer is really hard. So you may need to adapt some of the examination depending on what you actually have access to. But in an OSCE setting, hopefully all of this equipment would be provided for you. And lastly, it's worth thinking about the instructions that you're going to provide to the patient. So I wouldn't tell a patient that you're going to examine their cranial nerves, as that sounds quite scary. The words examine, cranial, and nerve put together is quite daunting, really. So you might want to say something like, you're going to test the nerves that supply your head and your neck. So use language that the patient is familiar with. So this is all really important, especially if you're performing this skill in an OSCE type scenario. Then these opening steps that you do in the first 30 seconds or so of your examination really sets the tone and helps build rapport with the patient. So that's my top tip as someone that examines a few OSCEs. Okay, so let's work through the nerves. Easy peasy. So cranial nerve number 1. So our olfactory nerve. So as the name suggests, this is really easy. So this is responsible for our sense of smell. So it's a sensory nerve. And how do we test this? Well, we don't really test it, to be honest. So outside of a specialist setting, such as maybe a neurology clinic, where they might have different things that you can smell, different smelling pots, including ammonia and other strong substances, we're not really going to formally test this. Instead, we might want to ask a screening question, such as, have you noticed any change to your smell or taste? So that's pretty simple. So you can easily test cranial nerve 1. So you just ask a screening question. So the cranial nerve 1 is the shortest cranial nerve. And if we think about clinical relevance, well, anosmia is loss of sense of smell. And pre-COVID, probably not many of us had heard of the term anosmia. We didn't use it much in clinical practice. But now, obviously, with loss of sense of smell being one of the key features, then that helps us maybe think about what are the causes of anosmia. Well, the most common cause of you losing your sense of smell is probably just a viral rhinitis or an upper respiratory tract infection, which damages the olfactory nerve cells. But a slightly more interesting clinical relevance point is head injury. So the olfactory nerve, the nerve fibers pass through this structure called the cribriform plate. And I've got this photo here, which I found on Wikipedia. So it's the cribriform plate of the ethmoid bone, and there's these tiny little holes, and you can see them here, the green arrow is pointing to them. So the nerve passes through the base of the skull and then supplies your olfactory nerve cells in your nose. So if you have a head injury, so maybe a whiplash type injury, or you have a coup and contacoup injury, so your brain is shaking about in your head, then it's very easy to shear these delicate nerve cells. And so therefore loss of sense of smell is quite a common finding after traumatic brain injury. So lots of patients complain over loss of sense of smell. So there we go, there's a clinical relevance point. And it's quite a nice clinical relevance point because you can think about the anatomy and you can work out why that occurs. Good, so we're not going to spend any more time on this because in our examination, we don't test this formally. So cranial nerve 2. So cranial nerve 2 is the optic nerve. So the optic nerve, as the name suggests, is responsible for our special sense of vision. And it's also the afferent limb. So by afferent, I mean input limb for the pupillary light reflex. So when you shine a light into someone's eye and their pupils constrict, it's the optic nerve that is telling the brain that a light is shining into the eye. So it's the sensory limb of the pupillary light reflex. So how do we test the optic nerve? Well, there's various things that we can do. So one of the things we might test is we might look at the pupils, we might test some pupillary reflexes, and that actually involves 2 cranial nerves, which is cranial nerve 2 and cranial nerve 3, which we're going to talk about shortly. We might test visual acuity, and that could be a very gross screening test, such as you just hand the patient some words written on a paper, a magazine, a patient information leaflet, whatever you've got lying about, and see if they can read it. Or if you're working in a more formalized clinical setting, then you could use something like a Snellen chart in order to formally assess visual acuity. We can do a gross assessment of visual fields. We can perform fundoscopy, so having a look in the back of the eye, and we can assess the blind spot as well. And the clinical relevance is very wide ranging. So there's obviously lots of conditions that can cause visual problems. And the challenge is that the problems can be anywhere really, from the front of the eye, you could have a cataract, to the back of the brain in the occipital cortex. You could be having a posterior circulation stroke, for example. So there's a wide range of clinical relevance, and we obviously don't have time tonight to go through everything, but I'm going to try and pick up on some really key points. So let's start by thinking about the pupillary reflex. So the pupillary reflex, as I mentioned before, involves 2 different cranial nerves. And what I find interesting about the pupillary reflex is that it's found its way into kind of general public knowledge. I mean, if you go on a first aid course, they start telling you about shining lights into people's eyes. And really what we're teaching people to do is a very small part of a cranial nerve examination when they do that. So let's have a look at this in a bit more detail. So the pupillary reflex involves 2 different cranial nerves, as I've already explained. And there's a diagram here illustrating this. So you shine, in this diagram, we're shining a light into the left eye, aren't we? Yeah. So it's the optic nerve that's sensing the light. So it's picking up that light signal, which takes the kind of the information to the brain stem, and then it's the oculomotor nerve, which is the third cranial nerve, which is taking the signal from the brain to the pupil, telling the pupil to constrict. And we know that there's a direct and a consensual reflex. So what do we mean by this? So a direct reflex is you shine a light into the left eye and the left eye constricts. And a consensual reflex is you shine a light into the left eye and the right eye also constricts, okay? Which is very useful. You walk into a bright room, you want both your pupils to constrict. So this is quite useful to understand that when you're testing pupils, when you're shining a light into someone's eye, you are testing two cranial nerves, okay? So optic nerve is the sensory component, the oculomotor is the motor component. And there's also an accommodation reflex, which I'm not going to talk about in a lot of detail, but you might see this in some of the clinical skills videos. If you ask a patient to focus on an object in the distance and then focus on an object in front of their eyes, for example, your fingers, then you notice that the eyes will constrict and the eyes converge as well to look at that object. So that's the accommodation reflex. So what's some of the clinical relevance of the pupillary reflex? Well, here's just two examples. There's lots of examples, but I thought I'd choose two that are perhaps most relevant to people's practice. So the first thing, maybe linking back to the first aider example I used on the last slide. So people worry about pupillary reflex in the context of head injury. And so what they're really worried about is this concept of, you might have heard this, blown pupil, as it were. So what's going on here? Well, if you sustain a major head injury and your intracranial pressure starts to increase, so the volume of blood inside your head is increasing, maybe because you've sustained a horrible extradural hematoma, or goodness knows, or you've got a lot of contusion, who knows. Anyway, the pressure inside your skull is increasing because your skull is a fixed box. And then you've probably heard the term of, you get herniation and coning of the brain. So coning is where your brain is kind of forced down through your foramen magnum, and that's terrible. But before then, you might herniate, so you might push part of your temporal lobe, so the uncus of the temporal lobe might move downwards, and that compresses the oculomotor nerve. And that causes, and I've indicated this as the red kind of symbol on this diagram. So you damage the oculomotor nerve, becomes compressed by the uncus of the temporal lobe as your intracranial pressure rises. So therefore, the pupil is unable to constrict. Therefore, you see that clinically as the pupil being dilated. Okay, so the pupil becomes dilated and unresponsive because the oculomotor nerve supplying it has become damaged by this increase in intracranial pressure and the uncus of the temporal lobe pushing on it, essentially. That's one example where, you can tell that that's a problem with the oculomotor nerve, so that's some clinical relevance. Or you might have a problem not with the oculomotor nerve, but you might have a problem with the input pathway of the pupillary light reflex. So this is damage to the optic nerve. And a common example of this, relatively common, is, for example, a condition you might have heard of called optic neuritis. So optic neuritis is inflammation of the optic nerve. It's a relatively common presenting feature of multiple sclerosis. Young female patients that present with blurred vision, pain on eye movements, etc. But also severe retinal pathology can cause this. So there's lots of other causes, but you clinically get this phenomenon called a relative afferent pupillary defect, or RAPD. So you might have seen this if you've read a textbook and it's talking about visual problems. And this is where there's no problem with the oculomotor nerve, it's working fine, but it's the input pathway, it's the optic nerve, which is damaged. So let's see what happens in an RAPD. So in an RAPD, so here we've got a diagram showing normal pupillary light reflex. So this is the one, if you look at the screen, it's on the left. So in a normal pupillary reflex, both eyes are dilated. You shine a light in the left eye, and the left eye constricts, direct reflex, and the right eye constricts, indirect reflex. And then you swing the light from the left eye to the right eye and vice versa. And both pupils remain constricted, okay? And that's normal, okay? That's what should happen. So you might see this referred to as the swinging light test for an RAPD. Okay, so we'll go through that again. So you shine a light in the left eye, both eyes constrict. You move the light from the left eye to the right eye, both eyes remain constricted. That's good. There's no problem with the input pathway. But here we can see an example of a right relative afferent pupillary defect. So in this situation, we start off in the same situation. Both eyes are dilated. We shine a light into the good eye, so the healthy eye. Both pupils constrict. Why do both pupils constrict? Because the oculomotor nerve is working on both sides, and the optic nerve is working on the left-hand side. Okay, so that's normal. But then you swing the light from the left eye to the right eye, and the right eye, there's a problem with the optic nerve. It's inflamed, or it's damaged, or it's not working at 100% for some reason. So you shine the light from the left eye to the right eye, and suddenly the eyes dilate, okay? You swing the light back to the left eye, and they constrict. You shine it back to the right eye, and they dilate. And that's abnormal, and we would describe that as a right relative afferent pupillary defect. So if this is a bit confusing, and I completely understand if it is, there's some really good examples on YouTube. So go away, have a look at YouTube, and there's some real life examples and some explanations as well. So this is an RAPD. Right, good. So we've talked about pupils. Let's move on and think about other aspects of cranial nerve number 2. So we also might want to assess visual acuity and color vision, sorry. So to assess color vision, we would use Ishihara plates. So these are probably, you might have come across these if you go for an eye test, or you go to the Specsavers and they ask you to look at these different color plates. And these are testing your color vision. And color vision can be disrupted, for example, in optic neuritis, where there's a problem with the optic nerve. You lose the ability, for example, to see bright red colors. So that might be something that you might want to test if you're doing this in an OSCE setting. But if you're working in your run-of-the-mill A&E department or primary care setting, you're probably not going to have access to Ishihara plates. But what you probably would have access to is a Snellen chart. And it's worth recording visual acuity, because this is a useful measure of whether a patient has optic nerve dysfunction. So a Snellen chart is named after, I think it's a Dutch ophthalmologist, Herman Snellen, and he wanted to come up with a way of accurately recording a patient's visual acuity. So a Snellen chart here is just a series of letters. We've probably all used one of these when we go for our eye tests, and you ask a patient to read down the list. And it's useful if a patient does wear glasses, we should get them to wear them during the, when we're testing their visual acuity. And then you record a Snellen chart at 6 meters or 20 feet, depending on what system you're using. And then you record it as a fraction. So for example, we can see here, if a patient, sorry, I promise I don't have COVID, I've just got a niggly cough tonight. So we can see here, if a patient has, for example, they can read down to line 5, which is 20/40. So what that means is the person can read at 20 meters what a person with normal visual acuity could read at 40 meters. So that's how you would interpret a Snellen chart. If you're performing this in an OSCE, you might not always need to use the Snellen chart because there isn't time maybe in the examination, but it's something that you should offer to do. Right. So let's move on to visual fields. So this is I've put in a picture from Hitchhiker's Guide to the Galaxy, telling you not to panic for this, because this can be really, really daunting when you're first performing a cranial nerve examination. So in order to test someone's visual fields, we use confrontational testing. So by that, I mean, you sit opposite the person and you, for example, they cover up their left eye and you would cover up the eye that's facing that eye. And then you would move your fingers and compare your visual field to the patient's visual field. And this is a very gross method of trying to detect a visual field deficit. More formal testing of visual fields involves using an Amsler grid, which is used in ophthalmology departments. For example, if you want to detect a more subtle visual field deficit. So this is a really complicated diagram, which we'll go through quite briefly. And it's from a great website called almostadoctor.co.uk. So I really recommend checking them out, as they provide lots of great resources. They're a bit like Geeky Medics. So the thing with the visual pathway is that the optic nerve fibers cross over at the optic chiasm for the medial aspect of the visual field. And the lateral fibers go to the ipsilateral side. So if you have a problem, let's work through the numbers. So if you have a problem before the optic chiasm, so here's number 1. So this is a problem with the optic nerve itself, just behind the eye maybe. So in that situation, you would get monocular visual loss. So you'd be completely blind in one eye. And that makes sense. You've disrupted the nasal and temporal fibers of that eye. If you had a problem at the optic chiasm, so classically this is a pituitary tumor or a pituitary growth, then that compresses the optic chiasm itself. And in that situation, you knock out the temporal aspect of both of your eyes. And we call that a bitemporal hemianopia. So if any of you are medical students listening to this, this is a classic medical student exam question, is what does a pituitary tumor give you from a visual field deficit point of view? You get a bitemporal hemianopia. So that's where you've lost the temporal aspect of your visual field, and that's due to compression at the optic chiasm. If you have a problem behind the optic chiasm, and one of the most common ones is a homonymous hemianopia, which is a common visual field deficit in a stroke, then you lose half the visual field, but on the same side. And you can see that illustrated in the diagram. And then it gets a bit more complicated. You can get quadrantanopias if you damage different radiations, either in the parietal lobe or the temporal lobe. And I'm not going to go into that into a lot of detail. There's more information on the Almost a Doctor website if you're interested. And lastly, if you have a problem with the occipital lobe, so for example, a posterior circulation stroke, then you also get a homonymous hemianopia, but you might have macular sparing of the central aspect of the visual field. So hopefully this makes sense. So once again, if you're a bit confused about this, there's some great videos on YouTube that go through this. And this is particularly important if you're thinking about assessing for visual field deficits in the context of stroke, because we know that homonymous hemianopia certainly can be a feature of anterior circulation strokes. And this helps you pick up the deficits. And once again, remember though, that your gross visual field testing that you see in a Geeky Medics video that involves you sitting opposite the patient is only going to pick up a gross visual field deficit. So you should be able to pick up a homonymous hemianopia or a bitemporal hemianopia, but you might struggle to pick up a more subtle quadrantanopia. Okay, great. So you've had to put up with me coughing through optic nerve and olfactory nerve. So I do apologize that I sound about 90 at the moment. I'm sorry about that tonight. So let's move on and think about the other cranial nerves, which sadly are also related to eyes. So these are the nerves that control our eye movements. And this is something I got a bit confused about when I was first learning the cranial nerves when I was a medical student. And that's the optic nerve is just a sensory nerve. It's not responsible for your eyes moving about the place. So it's different set of nerves, motor nerves, that supply your eye movement, your muscles that move your eye. So make sure you get that distinction kind of right in your head. So there's 3 nerves that we tend to test together that are responsible for your eye movement. So they're quite easy to remember. So cranial nerve 3, which we've already mentioned as being the efferent limb of the pupillary light reflex, supplies all of your extraocular muscles apart from superior oblique and lateral rectus. And once again, it does the pupillary constrictor muscle, which we talked about before. So therefore, the other 2 cranial nerves are responsible for superior oblique and lateral rectus. And the way you remember this is you think about a postcode. So the postcode is SO4 LR6. So superior oblique is cranial nerve number 4, which is the trochlear nerve, and LR6 is lateral rectus, which is the abducens nerve. Okay, so if you're ever wondering how to remember the muscles of eye movement, it's SO4, LR6, all the rest are 3. That's how you remember. So superior oblique is cranial nerve number 4, lateral rectus is cranial nerve number 6, and all the rest are cranial nerve number 3, which is the oculomotor nerve. There we go, easy peasy. So so the different muscles are responsible for moving the eyeball in different directions. And there's a diagram here that shows you what each muscle does. So for example, the lateral rectus abducts the eye. So it moves the eye away from the midline. And that gives you a clue, though, as to where the word abducens comes from. So the abducens nerve is responsible for the lateral rectus muscle, which abducts the eye. So it does make sense when they named these nerves. So let's have a look at how the eye moves. Now, I'm not going to go into this in too much detail. There's a whole field of medicine of neuro-ophthalmology, which does not interest me in the slightest, but it's worth thinking about which muscles are responsible for eye movement in different planes. So lateral rectus is responsible for abducting the eye, so moving the eye away from the midline. Obviously, medial rectus is responsible for moving the eye towards the nose into the midline. And then your superior rectus, you look up, inferior rectus, you look down, and the superior oblique and the inferior obliques do a combination of up and down with a bit of rotation as well. And so how can we test these nerves? Well, we ask the patient to keep their head still and they follow our finger. And the typical kind of movement that we use is the rugby posts or the H test. And the idea of this is that you're testing all of these muscles. So by doing a H test is you're testing elevation, abduction, adduction, etc. So you ask the patient, do you need to provide really clear instructions to the patient to keep their head still, and then just to follow your finger or your pen or whatever. And then you do the H test and you move their eye through all of these directions. And you're trying to pick up a cranial nerve palsy affecting one of these nerves. So let's have a look at one of these cranial nerve palsies and let's think about some clinical relevance. So one of the palsies you might come across is an oculomotor nerve palsy or a third nerve palsy. So in this situation, you've knocked out all of your extraocular muscles, all of your eye movement muscles, apart from lateral rectus, which remember is your abducens nerve, and your superior oblique, which is your trochlear nerve. So therefore, the pupil, the only nerves working, cause the eye to rest in a down and out position, which you can see here on this photo. You can see here this patient's left eye is resting in a down and out position. You also get ptosis, which is a droopy eyelid, because the oculomotor nerve supplies the muscle just above your eye. So you get a droopy eye. And you can also sometimes get pupillary involvement. So you get mydriasis, which is pupillary dilatation. And we can see that in this photo here. We can see the eye is in the down and out position, and we can see that the pupil is dilated. Okay, so this is a complete oculomotor nerve or third nerve palsy. So there are lots of causes of an oculomotor nerve palsy, but broadly you can have a non-traumatic oculomotor nerve palsy, a medical third nerve palsy, which a common cause is diabetes. And those tend to spare the pupil. So in a medical third nerve palsy, a non-traumatic third nerve palsy, the pupil will still be working okay, but the eye will be rested in the down and out position. In a surgical third nerve palsy, such as, remember, we were talking about raised intracranial pressure, or if you've had a hemorrhage, or you've got a posterior communicating artery aneurysm, then the pupil will be involved. So there'll be pupillary dilatation and it will be unreactive to light. So that's an example of some clinical relevance that you might come across in your cranial nerve exam and oculomotor nerve palsy. So you'll be thankful that this is all I'm going to talk about this evening when it comes to eyes. Okay, so like I said, there's a lot more. There are various other tests and reflexes that you can go into that are much more detailed than this. But this is a broad overview of the tests that you might be expected to do in a simple bedside cranial nerve examination. So let's move on and have a look at some of the other cranial nerves. So the trigeminal nerve is a mixed sensory and motor nerve. So the sensory aspect is the sensation to the face, and it's split into 3 branches. So you have your ophthalmic branch, your maxillary branch, and your mandibular branch. So we kind of shorten those to V1, V2, and V3. So you can test these by just asking the patient to close their eyes and whether they can feel you touching your face, and you might use a piece of cotton wool to do that. So you can test the sensation. And the other thing is that you can inspect the muscles of mastication. So those are temporalis and masseter. Those are the muscles that we use to chew with. And you can palpate the muscle bulk if you want to. And you can also offer to do the corneal reflex as well. And that's where you touch the cornea with a bit of cotton wool and the patient should blink. And it's the trigeminal nerve, which is the afferent portion of that. And there's something else that you might see in some of the clinical examination textbooks is a jaw jerk. So that's where you ask the patient to open their mouth. You place a finger here and you strike it with a tendon hammer. But that's not something that I really routinely do in clinical practice. So this is the trigeminal nerve. So relatively simple. So let's have a look at some clinical relevance. So here we can see a condition called Herpes zoster ophthalmicus. And this occurs when the Herpes zoster, the shingles virus, reactivates in the distribution of the ophthalmic division of the trigeminal nerve, or V1. And you can see here in this photo an illustration of the sensory distribution of V1 quite nicely, because you can see that the shingles rash and the vesicles and the horrible blistering is only occurring in the V1 distribution. And this is quite a horrible condition because you can get involvement of the eye itself. So you can get blistering and you can get keratitis, and it can be sight threatening. And these patients need quite aggressive treatment with antivirals and to have ophthalmology involvement. And the patients you need to worry about are those that have involvement of the tip of the nose. And this is called Hutchinson's sign. And if that's involved, then that suggests that the patient is much more likely to have involvement of the cornea and the eye itself. So this is just an example of a condition affecting the trigeminal nerve and V1, and something that you might see in clinical practice. Okay, great. So we've talked about the trigeminal nerve. So we're going to jump now, because remember, we've already covered the sixth cranial nerve, the abducens nerve, we're going to jump straight to cranial nerve number 7. So cranial nerve number 7 is the facial nerve. And this is responsible for the muscles of facial expression. And it also supplies stapedius. And it supplies taste to the anterior 2/3 of the tongue. And it also provides some parasympathetic supply to our lacrimal gland, so the tear duct, and also some salivary glands. And how do we test this? Well, we ask the patient to do a range of silly facial movements, because what we're trying to do is we're trying to test the facial muscles. And we might want to ask about hearing involvement or hearing changes. So they might develop hyperacusis in a facial nerve palsy. So that's where sounds appear much louder, because stapedius is responsible for dampening down sounds. And clinical relevance, well, facial nerve palsy, of which there are many, many causes. And there's actually a charity in the UK that is dedicated to raising awareness of facial nerve palsy. And you can go to their website and read about all the weird and rare causes of facial nerve palsy. And there's lots of information on there. It's quite a useful resource. So one of the causes of facial nerve palsy that's relatively common, and you might well have come across in your clinical practice, is a Bell's palsy. So what is a Bell's palsy? Well, a Bell's palsy is an acute idiopathic facial nerve palsy. So idiopathic means we don't really, there's no secondary cause of the palsy that we know about. So for example, the patient hasn't had an operation, they haven't had trauma, it's just something that's happened. And it's thought to be related to a viral infection, although no one's really sure. So a Bell's palsy can be quite dramatic because patients lose facial tone and the use of their facial muscles completely on one side of the face, okay? Which is really it's quite a dramatic presentation. So they get facial muscle weakness. They can get other symptoms as well. So they can get a dry mouth, because remember, the 7th nerve supplies some salivary glands. They can get a change in taste, because remember, it supplies the anterior 2/3 of the tongue. And they can get hyperacusis as well, because remember, it supplies stapedius. So a facial nerve palsy, or a Bell's palsy, is quite easy to detect. And we'll talk about how you distinguish this from a stroke in just a minute. From a treatment point of view, it's generally a self-limiting condition, but it can take months to get better. So you need to warn patients about this. And if they present early, so within about, I think it's 72 hours, then we can give them some prednisolone, high-dose prednisolone, which may shorten the duration of the condition. Another condition you might come across, especially for any medical students listening, is Ramsay-Hunt syndrome. And this is when the varicella zoster virus kind of reactivates or attacks the 7th cranial nerve ganglion. And you get symptoms of a facial nerve palsy, and you also get a vesicular rash in the ear. So it's important to look in the ear of anyone presenting with a facial nerve palsy. So I've put a link to the NICE clinical knowledge summary, and it's worth having a look at that if you're interested in Bell's palsy, or if this is something that you come across in your clinical practice, as there's a load of evidence-based guidelines there for how you assess and manage this condition. So I really recommend you go and have a look at that. So you might be wondering, isn't this patient FAST positive? And you sort of are correct, in that they do have facial weakness, don't they? So how do we distinguish a stroke from, for example, a Bell's palsy? Well, it's all to do with the forehead. So in Bell's palsy, the problem is with the facial nerve itself, okay? For example, it's been damaged due to a viral infection, we think. But in a stroke, the problem is in the primary motor cortex in the brain. And the way that the facial nerve is set up is that the forehead, the upper part of the face, receives information or input from both motor cortexes. So both sides of your brain are innervating the top part of your face, your forehead. So if there's a problem with the actual facial nerve, then you lose motor function to the upper and lower part of your forehead. It's all knocked out because the problem is with the facial nerve itself. But if you, for example, have a stroke, you damage that motor cortex. Because the upper part of your face receives bilateral input from your motor cortexes, then the forehead is spared during a stroke. So therefore, if you're wondering about, has this patient had a Bell's palsy, have they had a stroke, then you need to look at the forehead. And I've put an article here to a great article from GEMS, which goes into this in a bit more detail. But basically the key is in the forehead. And there's also a good YouTube video as well. So if they've got complete paralysis of one side of the face, this is a lower motor neuron problem, a problem with the nerve itself. It's a Bell's palsy. If they have forehead sparing, this suggests it's an upper motor neuron problem, a problem in the cortex, such as an ischemic stroke. So hopefully that makes sense. I hope I've explained that well. Well, I've managed to explain it without coughing, therefore I'm wondering that I have explained this well. So we've talked about the seventh cranial nerve, we've talked about the facial nerve, we've talked about Bell's palsy, and we've talked a bit about fast positive, isn't this a stroke, etc. So let's move on to our next cranial nerve. So we're going to move on and we're going to think about the vestibulocochlear nerve. So I like things that make sense, and this makes sense because the vestibulocochlear nerve tells you exactly what it does. So it supplies your vestibular system, which is responsible for balance, and your cochlear system, which is obviously responsible for hearing. So how do you test this? Well, there's not much you can do at the bedside. You can do a gross hearing test. So you can whisper something in the patient's ear whilst they block off their other ear. But this is a very gross assessment of hearing. More formal hearing tests are done with an audiogram, and that's probably what you would need to do if you were worried about someone's hearing. And you can also use Rinne's and Weber's tests, which I'm going to talk about shortly. And more specialized vestibular tests, you probably wouldn't do these at the bedside, but you might have read about these, and it depends on the clinical setting. For example, if you think a patient has benign paroxysmal positional vertigo, so they've got bits of debris floating around their vestibular system, then you could do the Dix-Hallpike test. And once again, you can go and look these terms up if you're not familiar with them. So let's look at Rinne's and Weber's test, because this does come up in exams. So Rinne's and Weber's test use the tuning fork, which I was talking about earlier, as part of your equipment for the cranial nerve exam. And Rinne's and Weber's test work on the basis that air conduction is better than bone conduction. So that's the first thing that you need to get right in your head, that air conduction is usually better than bone conduction. And when you're thinking about hearing loss, you can have two types of hearing loss. You can have a conductive hearing loss, or you can have a sensory neural hearing loss. So a conductive hearing loss is, as the name suggests, it's that there's a conduction problem. And the most common cause of this is earwax. So if your ear canal is blocked with earwax, then the sound is not able to conduct through to your cochlea and to your hearing apparatus. Whereas sensory neural hearing loss is a problem with the nerves. So that's the nerve supplying the cochlea, or the nerve supplying, for example, the vestibulocochlear nerve itself. So these are the two types of hearing loss that you need to kind of get right in your head. So conductive hearing loss, which is common, or you can have sensory neural hearing loss. So Rinne's and Weber's help you distinguish between these two. So Rinne's test involves striking the tuning fork, holding the end of the tuning fork that's vibrating next to the person's external auditory meatus. And then when the sound disappears, you place the base of the tuning fork on their mastoid process. And normally, the patient should be able to hear it again. Or another way of doing it is striking the tuning fork, placing the end of the tuning fork in front of the ear, and then immediately on the back on the mastoid process, and asking the patient which one is louder. Okay, so air conduction is where it's placed in front of the ear, and bone conduction is when it's on the back of the mastoid process. And usually, because air conduction is better than bone conduction, the patient should hear it loudest in front of the ear. So in health, so in normal situation, air conduction should be better than bone conduction. And we call that a positive Rinne's. So it's quite unusual because it's a test that's normal when positive. So Weber's test is slightly different. This is where you strike the tuning fork and you place it in the midline, so maybe on the forehead. And if there's sensory neural hearing loss, so for example, there's damage to the vestibulocochlear nerve, Weber's test will be heard loudest in the normal ear, because there's sensory. For example, if I do a Weber's test on myself and I strike the tuning fork and I place the tuning fork on my forehead and I hear it loudest in my right ear, then that suggests that there's a sensory neural problem in my left ear. So this is how Rinne's and Weber's test can be used to help test whether there's a hearing problem, is there sensory neural hearing loss, or is there conductive hearing loss. Interestingly, if there is conductive hearing loss, so remember we said that the most common cause of conductive hearing loss is wax, then Weber's test will be loudest in the affected ear. So for example, if my right ear is blocked full of wax, and I strike the tuning fork and I place it in the middle of my forehead, then I will hear that sound, that bone conduction, loudest in my right ear. And you might think, whoa, that doesn't really make sense. Why are you able to hear the sound loudest in your affected ear? And the reason for that is because your bone conduction, you can hear it better because you're not exposed to, you don't have atmospheric sound. So the way you can test this on yourself is if you block off one of your ears, your voice sounds loudest in that ear. Or if you start humming, that humming sound is loudest in the ear that you've blocked off, which is sometimes people find that a bit confusing. So this is Rinne's and Weber's test. Once again, this probably isn't going to be something you're going to be doing unless you're working in a clinic setting or you're performing this in an OSCE. And if you're doing this in an OSCE, this definitely always comes up. And this sometimes trips up quite a lot of students. So we've talked about the vestibulocochlear nerve. We've talked about Rinne's and Weber's test, and hopefully I haven't confused you too much with air conduction and bone conduction. You can always go and have a look at this on YouTube if you wish. So let's move on, and we've nearly finished our deep dive through the cranial nerves. So the glossopharyngeal nerve is usually tested in conjunction with the vagus nerve. So the glossopharyngeal nerve does pharyngeal sensation. It also takes sensation from the posterior third of the tongue. It does a few other things. It's the afferent limb of the gag reflex. And it also gives some motor innervation to stylopharyngeus. So really the glossopharyngeal nerve is supplying your sensation to the back of your pharynx, a bit of taste, and your parotid gland. That's really what it's doing. And in a cranial nerve exam, we test this in conjunction with the vagus nerve, because the vagus nerve is responsible for, well, it does loads of things outside the head and the neck, doesn't it? The vagus nerve does lots of things, but it innervates the soft palate, the pharynx, and the larynx. So really the only thing we test in a cranial nerve examination at the bedside would be, for example, swallowing. So asking the patient to swallow a glass of water, to notice whether they've got any dysphagia. We might also ask them to say "ah" and look for any uvular deviation. But that's about the limit of what we're testing at the bedside. But it's worth remembering that the vagus nerve does loads of other things. So remember, it's the main parasympathetic nerve supply to the thorax. It's responsible for parasympathetic supply to the heart. And you've probably heard about things such as vagal tone and vasovagal syncope. So that's where you activate your parasympathetic nervous system and you reduce your heart rate and reduce your cardiac output. And if you have syncope, you fall over because of this. And you might have come across various maneuvers that, for example, we perform for example, a tachycardia. You might try and increase a patient's vagal tone by doing carotid massage or a Valsalva maneuver, and you're trying to activate the parasympathetic nervous system and the vagus nerve. Something else that you might offer to do in an OSCE is to offer to test the gag reflex, and you would basically poke the back of their mouth with a soft tip, but that's not something you should actually do because it can be very uncomfortable for the patient. So don't actually do that. Yeah, someone says easily done with a COVID swab. Yeah, definitely. So the vagus nerve does lots of things. So don't think that a bedside cranial nerve exams, you're not testing all of the functions of the vagus nerve. You're just testing those motor functions to do with swallowing and the pharynx. And we're not going to go into the detailed anatomy of the vagus nerve. Okay, so we're nearly there. We're nearly there. We've got to cranial nerve number 10. So it kind of, once you've got here, you're in your home straight. So if you're doing this in an OSCE, this is where you can start to breathe a sigh of relief because it starts to get easier. So cranial nerve number 11 is our spinal accessory nerve, and this supplies sternocleidomastoid and trapezius. So in order to test this, you just test the two muscles. So see if a patient can shrug their shoulders against resistance and see if they can do resisted head movement. So you look to the left and you provide some resistance. And the accessory nerve runs quite superficially in the neck. So it's quite vulnerable to iatrogenic injury. So for example, a patient that's had neck surgery and they've had neck dissection for maybe a head and neck cancer or a lymph node dissection, then it can be quite easy to damage the accessory nerve, and they have weakness of these muscles. Okay, good. So that's the accessory nerve. So it's pretty simple to test. And then last but not least, we're onto the hypoglossal nerve. So hypo just means underneath or low, and glossal means tongue. So this nerve was named because it arises from the bottom of the tongue. And it's responsible for intrinsic and extrinsic muscles of the tongue, but it's not responsible for taste. So remember that taste is two other nerves. So it's two completely separate nerves. So this is just the motor function of the tongue. And to test this nerve, you just look at the tongue, look for tongue wasting or fasciculations, look for tongue deviation. So usually it deviates towards the side of the lesion or towards the weak side. And there are various other tests that you can do. So one of them is you can ask them to push their tongue on the inside of their mouth, and you can push against the cheek and push against the tongue to check the motor function. And the hypoglossal nerve, I'm sure there's one of those Facebook, there's viral posts on Facebook that provide very dubious medical information. I'm sure there's one going around about how tongue deviation is, the most sensitive sign of stroke or something like that. But I think about a quarter of patients with an acute ischemic stroke might have an element of tongue deviation. But they'll also have those other signs and symptoms that you would expect with a stroke. So they'll probably have a hemiparesis as well, which will be a bit more obvious than this. Great. So once you've got here, you've got to the last cranial nerve. I'm just looking at the time. So we've run a little bit over, so I apologize. But as you're finishing up your examination, you would probably going to examine the rest of the neurological system. So it's important to do the limbs as well. And I've got a webinar coming up about where we're going to be looking about the upper and lower limbs, because it would be rare just to examine the cranial nerves in isolation and not do the rest of the limbs. You would probably want to perform fundoscopy, and that would allow you to look at the optic disc. And if you remember, the optic disc is kind of the start of the optic nerve, and you would be looking for things such as papilledema. So that's a useful thing to do in a cranial nerve examination. And then you might want to offer to perform a more formalized hearing assessment or an audiogram. So my top tips are YouTube is great for signs. So if you're sat here thinking, this is a bit overwhelming, what does an oculomotor nerve palsy look like? Just put oculomotor nerve palsy into YouTube, and there's a couple of videos that show you this in real life. So that's a really good way of learning to pick up these physical signs. Practice makes perfect. So practice, practice, practice. Even if you don't have access to all the equipment, it doesn't really matter. Don't make it up. So if you're really not sure what's going on, don't say that you've tested a cranial nerve if you haven't. So it's really important not to make it up. And keep clinical relevance in mind. It's a lot easier to learn if you know the clinical relevance. So those are my top tips. And then good resources are, we all know about Geeky Medics. OsciStop provide great summary sheets. If you're testing each other on cranial nerve exams, OsciStop is quite good because it's much more condensed than Geeky Medics. And the best textbook I recommend is Neurological Examination Made Easy, which you can pick up a copy for about £10. So it's a really good book. It's really quite simple, and it goes through the whole neurological examination and provides the underlying anatomy and physiology that you need to know. So those are the good resources. And that's about it. So I really apologize that I sound, you know, pretty terrible this evening with my croaky voice and cough. So I do apologize about that. Hopefully you're able to concentrate beyond me coughing and spluttering in the background. But hopefully you found this useful. And if you have found this useful, then it's probably worth coming along to the webinar next month about the upper and lower limbs. And we can try and piece some of these things together and think about the neurological examination as one. But otherwise, I will hand back over to you, Andy.
Excellent. Thank you, Chris. As always, it never matters if you run over, because actually the subject is so fascinating and so interesting. You've managed to engage a fabulous audience of almost nearly 840 people tonight. So I have to say, just simply amazing. We have got a few questions. If you are a member, just remember that your certificate will come automatically. We've already got 70 emails asking when they'll get the certificate. So if you are a member of CPDme, your certificate will be automated. It will be with you tomorrow before dinner time. If you're not a member, you can scan that QR code on screen, and that will allow you to purchase a certificate for £1.99. But I will post the links again in the chat, but it is moving so fast you will have to scroll up and catch it, where you can join and have a £1.99 trial for the next month. And that means you can catch all of the webinars for the next 30 days and get all of your CPD certificates, FOC, or free of charge. I'm just gonna let Dr. Chris have a drink. I was drinking for you almost throughout that entire webinar.
Oh, thanks. I struggled through. I got there.
I've got some lateral flow tests if you really want one. But I'm sure you are tested daily, as I know you do lots of work. There's lots of things I need to tell you, but in a very short period of time. And so we're going to go through questions and answers, and then I'm going to tell you the next 5 up and coming free webinars. And then also I'm going to tell you about a great new addition who's coming on. So we've got, in fact, I'll tell you now, we've got a new clinician called Dawn who's coming on board with us shortly. And Dawn is going to come on board and hopefully put some, you won't believe this, face-to-face CPD courses for our CPD members. And we'll be holding them in 2 locations, one north of England and one down south. And so much exciting things to tell you, but I just can't tell you all on this webinar. But keep tuned in, and I shall release it a little bit at a time. Question from Daniel. What do we do in an ambulance setting as a paramedic without all this equipment that's needed to do a clinical examination of the cranial nerves? We are taught how to do the assessment, but just don't have the kit, Chris. Is there anything they can substitute it with?
That's a great question. That is a really good question. So firstly, in hospital, we often don't have the equipment either. So don't feel you're in isolation there. So a tendon hammer is like gold dust in an A&E department. And even in the GP surgery I'm in now, it's really difficult to find them. So there are a few things you can do. So obviously a pen torch, you can substitute with any light source. So that's pretty simple. A cotton wool tip, you can substitute. You don't have to use that to test light touch sensation. So you could use you could use a bit of gauze. You can even use your finger or your hand. A tendon hammer, you can actually use a stethoscope instead. So you can use the corner of a stethoscope It's quite difficult to explain this, but you just kind of hold it a couple of inches from the end of the stethoscope, and you can use it a bit like a tendon hammer. So there are substitutions you can do. Things that you're not going to be able to substitute are, you're not going to be able to substitute an ophthalmoscope. So in order to look at someone's retina, you would need that. And a tuning fork, you're not going to be able to substitute that for Rinne's and Weber's test. But how can I say this? I think it's probably not going to change your management much. And the utility of Rinne's and Weber's test in the clinical setting is dubious. And whether it provides a lot of useful clinical information in the real world, I'm not sure. But it's one of those things that is pervasive in assessment. So if you are preparing for an OSCE or you are preparing for an exam, I would learn that, because it's something that's very easy to test students on, but I wouldn't worry too much if in the clinical setting you don't perform it. So that would be my answer to that.
Excellent. Thanks, Chris. Karen has just put a really good tip actually in the chat. Newspaper headlines and text are really good for testing site pre-hospital. I'm just not sure how many people get newspapers anymore, Karen, but that's a really good tip. Thank you. We have got a question. It's actually a really good question, but what I might do is I might see if I can get Dr. Chris to do this, and we'll do a little 1 minute Twitter video. Will you be discussing how to document the findings or direct us with hints and tips on how to do this confidently? We can probably catch up, Chris, offline and do that, and maybe just do a little snippet for 2 minutes, do you think?
For documentation?
Yeah.
Yeah, so for the next webinar, we will go through documentation, because you can do a nice table for the upper and lower limbs about have you tested sensation, etc. For cranial nerves, I think my only advice for documentation would be don't write cranial nerves 2 to 12 grossly intact. That would be my advice, because that doesn't tell the next person anything about what you've tested. So I would just write down what you do. So for example, you could say, normal, visual acuity, such and such, normal eye movements, no difficulty in swallowing, normal facial sensation. It's much better to be specific regarding what you have and what you haven't tested than to use a term such as grossly intact, which means different things to different people. That would be my only advice.
Excellent and good advice. We have got another question. I don't even think I can say this, but I know what it is, David. When doing a cranial nerve assessment, would you agree that checking for dysdiadochokinesis, that is this thing, isn't it? Is that all right?
That's your flipping of the hands. Yeah.
Gosh, David, that's the blast from the past. You just reminded me from about 20 years ago at a good old local university when an old GP came in and taught us that term. But I'll leave Dr. Chris to answer.
Yeah, so I mean, we traditionally teach that as part of a cerebellar examination. So there's the mnemonic Danish, isn't there, for all of your cerebellar signs. So I think that this goes back to what I was saying earlier, is that you would never perform just a cranial nerve exam on its own. You would be performing this as part of your structured patient assessment, and you would probably test the upper and lower limbs. And if you were worried about cerebellar pathology, such as in the context of an ischemic event affecting the cerebellum or the posterior circulation, then you would be looking for those cerebellar signs. So you'd be looking for dysdiadokinesia, you'd be looking for pass pointing, you'd be looking for, I don't know, truncal ataxia and all of the things like that. So in your thinking about your neurological exam, it's meant to be a holistic, comprehensive assessment that you decide to do based upon the history. So you've taken your history and you've thought about your differential diagnoses, and then you perform a targeted examination to rule in or rule out your diagnoses. But when we assess clinical examination, we don't do it like that. We break it down into cranial nerves, upper limb, lower limb, cerebellar. And this is something that students struggle with because they learn these exams kind of in silos of cranial nerves or lower limb, etc. But when they go out into practice in the real world, they realize that as clinicians, we do a kind of a mishmash, a kind of hybrid of all of the examinations based upon what our thoughts are around the differential diagnosis.
Excellent. Thank you, Chris. Just a couple more questions. Malgazat is asking, hello, I would like to ask why some people have unequal pupils and this is normal for them.
It's got a name, doesn't it? Is it ansecoria? You're testing my... The only thing I know about this is David Bowie, isn't it? He's got unequal pupils. I think he got in a fight. So this is my pub quiz knowledge. And yeah, so it can be a normal variation due to various things. So it's not necessarily due to a problem with the nerve itself. It can be due to a problem in the eye. So it can be a problem with that pupillary constrictor muscle. So it might not be a sign of a neurological problem. It might be the sign of an eye problem. And it might be something that is a congenital problem that a patient just has. So oh yeah, someone's saying, yeah, he had heterochromia and anisecoria. I think that's how you pronounce it. Yeah, sorry about my pronunciation. But yeah, so in some people, that's going to be a normal variation, a normal finding. But in the clinical setting, you know, either the patient's going to tell you that pretty quickly, or their family members or their friends are going to tell you. But that is worth knowing about because these types of patients crop up in OSCEs. So if you think about what types of patients are going to occur in your clinical OSCEs, if your university uses real patients, they're going to find people with clinical signs which are stable and not acutely unwell patients. So patients like that may well crop up in your OSCEs, so be warned.
Excellent. Thanks, Chris. We've just got one question left. There's loads and loads of questions. I will pass some of these questions on to Chris and we'll try and sort of get them covered in the up and coming webinars. Lots of comments saying really good session. Thank you very much. Last one from Jutta. How reliable is the HINTS exam?
Okay, so I don't have the answer to that off the top of my head. So I wouldn't be able to tell you the sensitivity and specificity off the top of my head. It's useful in the context of acute vertigo, but the problem with the HINTS exam is that you need to be trained in its use, and I'm not sure about the inter-rater reliability. And really the whole point of it is you're trying to work out in a patient with acute vestibular problem or acute vertigo, is it a peripheral cause? So they've got, I don't know, a problem with their vestibular system, which we're not very excited about. We just give them some symptomatic treatment and send them home. Or do they have a central cause because they're having, for example, a stroke, in which case we're much more worried about that, and we would refer them to the stroke team and imaging, etc. But as for the sensitivity and specificity, I don't know that off the top of my head. So yeah, I'm sorry about that. I think it's in the NICE guidance though, so you could go and have a look at that.